This baby's heartbeat is 60 beats per minute, half the normal rate. It's a response to fetal hypoxia and a way to protect precious cardiac muscle. But as pH levels fall and lactic acid rises, brain cells begin to malfunction and die. In high-risk pregnancies, injury is more swift. If this was you or I, we would feel chest pain, would be nauseous, dizzy, slowly lowering ourselves to the floor. The midwifery and obstetric response to fetal bradycardia has to be swift. Roll the mother onto her side to release the baby from the umbilical cord compression. Do a vaginal examination to exclude cord prolapse. But ultimately, delivery is required. And in this short time, we have to talk about the options available to the woman. Now, this baby's heart rate is returning to normal. Anything over 100 means blood flow to the brain, and everybody takes a sigh of relief. But assisted delivery may still be required. In emergencies, there's often very little time to talk about consent before intervention's required. Even in less urgent situations, often the stress of labour can make it difficult for a woman to meaningfully engage in conversations. And tragically for many women, when their baby's heart rate is at 60 beats per minute, this is the first time they hear about forceps, vacuum, even caesarean section. And this lack of prior information can be devastating. The New South Wales Birth Trauma Inquiry, published 2 months ago, has made it clear how impactful and widespread these issues actually are. Induction of labour featured highly, lack of explanation or coercion in the course of interventions, being left to deal with shock and confusion after difficult births, and systemic failures around follow-up, continuity of care, and unclear consent processes. The second stage of labour is the pushing phase. So what do women want or need to know at that time when it comes to consent for interventions? In my survey of nearly 100 women, half of them wanted detailed information. And a smaller group wanted to be fully involved, but with a simpler approach. So what information did women receive during their antenatal visits? Shockingly, nearly half reported receiving no information about instrumental birth before labour, and a quarter had received only minimal information. The New South Wales Birth Trauma Inquiry brought to light critical factors regarding informed consent procedures in labour. 8 themes have been identified, and they're shown on these slides here. Inadequate information, particularly in emergency situations, lack of respect for autonomy, and non-consensual procedures, coercion by shroud waving or suggesting that the baby may be injured if an intervention is not agreed to, systemic issues with overworked staff, lack of continuity of care, and systemic failures to provide adequate support. There's a clear need to provide information about interventions that might be used in labour before labour. Lack of information can lead to psychological trauma and dissatisfaction amongst women who birth, and systemic changes are needed to ensure better informed consent. 150 years ago, a paternalistic approach dominated medical practice. Doctors decided what information was good for their patients to know, and nothing more. Contrast changing perspectives by 1989, as seen in these excerpts. Medical paternalism is no longer acceptable, and informed consent is upon us. The medical profession should accept the duty of careful disclosure. Informed consent is not a new concept, but its importance has become increasingly codified over the years. Since the late 2000s, it's been a fundamental part of the Medical Code of Conduct in Australia. This code emphasises the need for doctors to communicate effectively, ensuring that their patients understand clearly the benefits and risks of procedures that are undertaken. To understand the current state of informed consent, we need to look at how our practices and expectations have changed and evolved over time. By examining this evolution, we can then better understand what information should have been shared with an individual at a particular time. And this historical perspective is important because we will still be seeing historical cases coming over our desks. In the following slides, I'll provide the evidence base for what should have been shared during the informed consent process for interventions in the second stage of labour. We look to medical research that guided understanding for consent. There were 12 studies published in this 24-year period that specifically compared instrumental delivery with caesarean section. Now, early research outlined some basic information about the risks of obstetric anal sphincter injury, so third and fourth degree tears, which was of course limited to vaginal birth. Fever and blood transfusion were more common with caesarean section, and injuries to the baby, bleed on the brain known as intraventricular hemorrhage, was similar with both modes of delivery. This was confirmed in a study in the early 2000s, and the length of hospital stay was longer with caesarean section. Neonatal trauma risk was lower also. This next study wasn't a comparison of instrumental versus caesarean section, but it considered caesarean section in the first versus the second stage. Now, in the second stage of labour, the baby's head has moved deeper into the birth canal, and so there's been a belief that in the extraction process of bringing baby back up to the abdomen, that it may be more traumatic for the mother or the baby and resulting in higher injury rates. Now, to some extent, this was confirmed, and although the complication rate for the mother was slightly higher with second stage caesarean sections, there was no significant difference in T and J incisions, and these are the most complex incisions that are required to deliver the baby from an awkward position. There was no difference in other pelvic organ injuries such as bladder, bowel, or ureter. Larger studies with more participants have provided greater validity and clearer insights to the different delivery modes. And this period saw research comparing 18,000 forceps deliveries with 23,000 vacuums and caesarean sections. Now, there was an increase in neonatal injuries associated with the instrumental birth, and specifically neurological injuries were greater with vacuum than forceps. Encephalopathy is a condition that can precede cerebral palsy, and the rate was similar in both instrumental and caesarean section. And the risk of death was rare, but there was a trend towards caesarean section being protective. These findings underscore the importance of discussing the specific risks of the planned delivery with the parents so they can make an informed decision about what type of birth mode might be appropriate for them. We have 4 more studies to go. Now, the first 2 were quite interesting because they both considered babies that were born from a low pelvic station. As a baby moves down the birth canal, you can determine how far down it has gone by either feeling the baby's head abdominally and seeing how many fifths. So we divide the baby's head into fifth slices and then say how much you can feel above the pelvic brim. Or you can do a vaginal examination, and with a finger you can palpate the bony part of the pelvis here called the ischial spines, and that is called station 0. So there's an imaginary line between the 2 ischial spines. When the baby moves down the birth canal, below the ischial spines, it's said to be in the mid-cavity of the pelvis. So 0 to +1 is mid-cavity, +2 is a low station, and +3 is an outlet station where the baby is very close to being born. Now, it would be unusual in Australia to offer caesarean section at low station, at +2, but the United States had moved to liberal use of caesarean section, and this extended to low deliveries as well. This was a moderately sized study, as you can see. All babies were at low station, and caesarean resulted in a higher risk of maternal infection. Interestingly, instrumental delivery reduced the risk of birth trauma, but of course, third and fourth degree tears were still significant association with instrumental birth, with the rates of 9% and 4% for forceps and vacuum, respectively. But overall, other neonatal outcomes were similar. Caesarean section at low station remains unusual in Australia, except for when an attempt at delivery is made and it fails, and then the baby is delivered ultimately by caesarean section. Now, the 2 Maraca studies were significantly larger than any research to date. These involved all deliveries within Canada over a 10-year period of 2003 to 2013, and they were exclusively mid-pelvic deliveries, so babies that were at 0 station to +1. And this is the station where in Australia caesarean section is a valid and reasonable alternative. The data was large enough to be able to stratify even by why the instrumental birth or caesarean was done. Was it for fetal distress or because labour became obstructed? I won't go into the details about the stratification because it is nuanced, but overall caesarean section was found to be safer for the baby and safer for the mother. There was a 1 in 100 risk of serious injury such as fractures, internal bleeding or injury to internal organs by vacuum or forceps delivery compared to that risk of being 1 in 500 with caesarean section. Now, long-term risks were not considered in this research, including the effect of caesarean section on future pregnancies. So we've talked about fetal and immediate maternal risks, and now I want to shift our focus to the longer-term maternal implications of childbirth, and in particular to the integrity of the pelvic floor muscles, and particularly the levator ani muscle, that plays a significant role in the long-term health and well-being of women. Injuries to the levator ani muscle can include levator avulsion, where the muscle is detached from the pelvic bone, and this predisposes women to pelvic organ prolapse and incontinence in later life, conditions that are associated with reduction in quality of life. This 2021 review clarified the link between vaginal birth and pelvic floor injury, and ultimately the protective effect of caesarean section. Now, became clear that it wasn't until 2009 that this relationship was found to consistently be present. In the next few slides, we're going to explore the relationship between levator avulsion and mode of delivery and how these impact that risk. Prolapse typically begins with injury to the levator ani, or the pelvic floor muscle. That's shown here in this diagram as the whole sheet of muscle that sits below the baby's head. You can see separately the external anal sphincter, which is the circular muscle around the anus. Now, the levator ani is vulnerable to stretching injury during childbirth, but it's also vulnerable to being detached at its attachment on the top of the bony pelvis. Levator avulsion then can lead to pelvic organ prolapse, where organs such as the bladder or the bowel or the uterus can descend into the vaginal canal, significantly affecting the quality of life. The MRI scan here on the right-hand side of the screen shows a levator avulsion. The black arrow you can see shows the pelvic floor muscle attached to the pubic bone. If you look and compare that with the right side of the same MRI image, where the white arrow is, you can see that there's a detachment and the absence of that black appearance, indicating that the levator ani has been detached from the pelvic bone on that side. And the resultant effect is on the left-hand side of the screen, showing an anterior vaginal prolapse or cystocele. And this understanding of levator avulsion is crucial for providing comprehensive informed consent in labour, because instruments that we use have differing effects in terms of their risk of levator avulsion, and that's the conversation that we're going to cover next. The numbers in this table are going to show the factor by which certain conditions occur by delivery mode on the left-hand side. And so levator avulsion, you can see here, is 40 times more common following a spontaneous first vaginal birth. Findings of prolapse are 4.8 times more common, and symptoms of prolapse 2.6 times more common. Do subsequent deliveries result in levator avulsion after the first vaginal birth? The answer is not in general. Only around 1% of levator avulsions are due to a delivery after that first vaginal birth. As we know from the research that I mentioned previously, caesarean section is highly protective against injury to the levator ani muscle, preventing 90% of levator avulsion and 60% of prolapse symptoms. Forceps delivery increases the risk of levator avulsion by a factor of 6, and prolapse is 2.5 times more common after a forceps delivery. And vacuum delivery does not present a significantly increased risk factor for levator avulsion and prolapse. Most of the symptoms are already present with the fact of having a vaginal birth. Now, the corollary of this is that if a woman undergoes a vacuum for her second or third birth and then experiences prolapse, it's more likely that the injury occurred with her first vaginal birth, even though it was spontaneous compared to an instrumental for her second. And this might have implications for a lawyer's decision to proceed with the matter, as the primary injury may be already established with the first spontaneous delivery rather than the intervention that was required. So I've spoken about the medical facts, the pros and the cons, and the risks of the benefits of the different types of delivery that might be required in the second stage of labour. And it's interesting because not all women will choose a caesarean section, even though we've spoken about the harms that can come from instrumental birth. And in fact, my experience is that most women do not choose caesarean section in the second stage of labour. There's a body of research telling us that agency, the offering of choice, and an individual's perception of control has a role in mitigating the psychological harms of a traumatic incident. What else has informed obstetricians' expectations for consent in the second stage of labour? We've heard about the evidence. What about other key milestones and important cases that have informed their practice, and how have these changed over time? In 2011, the Queensland coroner, reporting on the tragic death of Samara Lee Hoy, spoke specifically about the importance of antenatal education. He emphasised that all women need to have access to balanced antenatal education and classes that clearly outline normal and abnormal labour and what interventions might be required if labour becomes abnormal. The coroner's recommendation included that both midwives and obstetricians be involved in antenatal classes. These recommendations emphasise the important role of antenatal education in ensuring informed consent. 7 years after the coroner's recommendation, the 2018 Guide to the Content of Antenatal Education Programs, however, did not recommend routine discussion of instrumental birth and interventions in labour. It recommended that these conversations are targeted rather than universal, for fear that they might focus too heavily on negative aspects of childbirth and cause undue anxiety. And I think we know from the birth trauma inquiry that in fact this has had the opposite effect. In the mid-2010s, Australia conducted an inquiry into the harms of pelvic mesh that's used for prolapse and incontinence symptoms. One of the overarching findings was the catastrophic failure of informed consent that took place during this time. The Senate inquiry brought significant attention to these issues, in particular placing obstetricians and gynecologists once again in the spotlight. The testimonies and submissions from the public revealed the real-life impact of failures of informed consent. This sentiment was reflected in news and media articles at the time, with particular reference to the childbirth space. Around the same time, the Montgomery case became a topic of conversation in obstetric circles. And although it was a UK case, the involvement of an obstetrician meant that it probably gained more attention than Rogers and Whittaker ever did. At the 2018 Ranscog scientific meeting, an hour and a half was spent discussing the implications of Montgomery for childbirth. In 2018, a significant tribunal report was published from Western Australia about an attempted vacuum extraction. The report highlighted serious deficiencies of the informed consent process, leading to a finding of professional misconduct against the doctor involved. The doctor failed to accurately describe the vacuum extraction technique, failed to discuss the pros and cons and alternative options, and therefore did not obtain proper informed consent. According to the tribunal, he should have followed the particular approach as outlined by the expert witness. And this particular approach informed discussing the pros and cons, risks and benefits, and alternatives as one would do during an informed consent conversation. The tribunal concluded that failing to do so was substantially below the expected standard of care, resulting in a finding of professional misconduct. This tribunal's findings clarify that the standards for informed consent must be rigorous and must be adhered to meticulously. These standards are designed to ensure that patient autonomy is respected and that women have choice. As we have seen, the evolution of informed consent has been shaped by research evidence, legal precedents, professional guidelines, and a growing understanding of the importance of patient autonomy. And by 2020, the emphasis on discussing the material risks specific to each patient highlights how essential it is for healthcare providers to tailor these consent processes to the individual in front of them. And this evolution reflects a broader commitment to patient-centered care and the ethical duty of ensuring that patients are fully informed about decisions relating to their health. And so here we are in 2024. The findings of the birth trauma inquiry have left us in no doubt about the significant gaps that remain in the informed consent process within the childbirth space. We now have a clear understanding of what needs to be discussed when we're dealing with intervention in the second stage of labour, and that information has to start in the antenatal period and has to include all women who might be at risk of instrumental birth. The evidence is unequivocal, and the responsibility sits with us as healthcare professionals, as policymakers and advocates in the childbirth space. The era of paternalistic medicine is over, and it has to give way to a practice that upholds the autonomy and informed choices of every woman. Clearly, this transformation is going to require concerted effort across states, territories, healthcare organisations and individual practitioners. But together we can pave a way for a safer and more respectful childbirth experience for women in Australia.